So let's welcome Dr. Kris Mullins.
I'm going to get my props real quick. Yes, in matter of fact, Alva and Washington, which is where I went to high school, Washington, Oklahoma, played in the state playoffs, and we got robbed at the final second by the referee. And we were looking forward to playing you again in the state playoffs, but you guys went down a class, so we didn't get to play you.
This year we're back up a class.
But Washington also fell apart last year.
Yes, we did. we made it to state, but then we had to play. It was a team out of Enid, I believe, wasn't it, or outside of Enid? Chisholm, yes. All right. Okay. Today I want to talk about coronary artery disease and to keep you out of my waiting room. Try to help you with that. Again, a little background information. I grew up in Purcell, Washington area. My mom and dad were farmer ranchers, and I say mom and dad because my mother was pretty much right there, the hired hand, the vice president, secretary, treasurer. We did soybeans and maize and corn in the summertime, and then did winter wheat in the wintertime, and ran about during the heyday when my brother and I were both there to be the other free hands. We ran about 1,000 head of feeder steers. My father, unfortunately, when he was almost 80, went to go check on a cow because we thought she was getting ready to have a calf, and he was on his four-wheeler that we had, we had horses and four-wheelers, and there was this peach tree in the fence row, and it was getting where the peaches were getting close. And he decided to take the four-wheeler up on the fence row to see if the peaches were ripe. And my mother was watching America's Funniest Videos, Sunday night, and before they got ready to go to church, and it was getting late. And he was going to be late for training union, and she kept, wondering where he was, or maybe the cow was getting ready to have the calf. And then she heard the dog bark, so she went out on the back porch, and the dog was barking and kind of running back, and she couldn't see where the cow was or my dad was. And then she looked down and saw the four-wheeler flipped over in the bar ditch. And so my dad died because of that. But at first, my world was totally turned upside down because, we sold everything. But, the fact that he was able to die on his own farm, not be in the hospital, it really was, after, getting over the grief and everything, kind of a nice thing that, he was able to live his life as full as he was. But let's talk about heart. The major thing that I want to get across to you is that, number one, things are in your control on some things with your heart. Some things are out of control as far as your heart is concerned. Your age, of course, that takes in consideration. As you get older, that becomes a factor. As you become, as far as more sedentary, that has something to do with it. But the major thing as far as family history, if used to, we didn't think family history had that big of an issue, but more and more I'm asking my patients, tell me about your family history. Does heart disease run in your family? The next thing, of course, is how active you are. Do you walk? Do you move? Do you sit a lot? The next thing, of course, is, are you diabetic? That is also a big issue that we ask about. And then, of course, the big T, do you smoke? I would had thought my nurses had ran this off for you, but I am going to, maybe we can, I wanted to give you a scorecard as far as give you the idea as far as things that we look for as far as when you come into the emergency room, they will add up your risk stratification when you come into an emergency room. Number one is, how old are you? Are you under 40? Are you over 40? With men, usually you will have your heart disease sooner than women. Women usually have their heart disease after when they start menopause. Men, it's usually around the 40 to 50 range when you start really, becoming at risk for having heart problems. Again, family heart disease, especially, we're not too concerned if mom and pop had, grandma or grandpa was the one that had a heart attack when they were in their 80s or 90s. We want to know, did someone when they were 45 or 50, if they had a heart attack? We kind of want to know that. Is it early onset? The second is, do you have high blood pressure? When we talk about high blood pressure, I want you, it's one of those things that I didn't realize. It's kind of like, why this magic number? Why 140 over 80? Where did that come from? My poor mother, she probably wanted to kill me a lot because I was one of those kids that I could not take no for an answer. It's kind of like, I wanted to know why. Don't just tell me no. You got to tell me why. Why are you saying no? Same thing with, why is 140 over 80? Where did that come from? Did somebody just pull it out of their hat or what? The reason why we started with 140 over 80 is that the insurance companies realized that people that had blood pressures that were in the 140s over 80s did not cash in their life insurance as soon as the ones that had higher blood pressures. So that's where that came from. We did try in the last 2 to 4 years, we decided that, well, if 140 over 80 is good, let's try 120 over 70. Let's try to get your blood pressure even down lower. Well, for me, I have patients that would do well with 120 over 70, but my older patients, especially my older, more frail female patients that weigh like 100, 110 pounds, they were getting dizzy. Of course, the orthopedic surgeons loved it because, of course, if they fall and break a hip, but 120 over 70 to 140 over 80 is sort of the range that we deal with now, or that we would like to keep your blood pressure in, because, again, less resistance on the heart. But, again, it has to be a happy medium. If you're getting up and you're getting dizzy, that's not going to work for you. So it's one of those you've got to take everyone in consideration. The next is cholesterol. There's been a lot of things about cholesterol in the news. There's also been things about fish oil in the news. We would like to keep your cholesterol around 200. That's the magic number. 200 to 230 on the total cholesterol. Now there's 2 sets of cholesterol parts that I want you to remember. There's the total cholesterol that I just said, and then the other is the LDL, which is the light density lipoprotein. That's the bad cholesterol. That's the kind of cholesterol that, I use this as an example, when I would, take a bath and I put, some type of, bubble bath or something. When I drain the tub, there's always a ring around the tub where the water, stayed. And that lipoprotein, that light density lipoprotein, does the exact same thing. It likes to hang around in your cells, in your lining of your vessels, and it's sticky. And so a lot of things, plaque, cholesterol, different things will stick to it, and then it'll start making a plaque, a fatty plaque. The good cholesterol is called heavy density lipoprotein, or HAPPY, if you can remember just for the H, and that's the heavy cholesterol. It's sort of like lava soap. It drains everything with it. It grabs stuff as it's on its way out, and so it takes a lot of the bad stuff out with it. So that's why we want you to have a good or a high density lipoprotein, and we like for that to be around 40 at least in men, 45 in women. And as far as the bad cholesterol, the LDL, we like for that to be less than 100. So those are the magic numbers. Now, As far as cigarette smoking, I don't think I really need to talk about that. Everybody knows there's warnings on that. It's just, if there's anything that we can do to help you not smoke, that's what we want to do. Now, diabetes, that is probably, besides smoking, having a family history, having diabetes, and having, as far as a very strong family history, is major. Diabetes is probably the number one reason why it gets to the point that I can't treat them anymore, because their arteries become so small it's almost like spider webs. And because of the sugar, the high sugar, and also because of the remodeling of the vessels, because of the high blood sugar, they just look like little pieces of hair. And they get too small and I can't even do anything with them. So that's what's going on with diabetes. So those are the risk factors for heart disease. So now I kind of want to show you some of the things that we do and just kind of pass around and answer questions. This is, and I'm just going to take it off the stand. If anyone wanted to know what does a bypass surgery look like, this is it. They actually will take, get back in my spot. They will actually take either a vein or an artery. The best bypass is the left internal mammary artery. It runs down the back side of the breastbone. You have two. You have the right and the left. Well, what the surgeon will do is that when they crack your chest open, they will actually dissect and take away that left internal mammary artery and plug it in to the heart, into usually the left internal mammary artery goes into the left coronary artery. Now, if he wanted to do something on the right side, he would use the right, just because you don't want to cross over the heart or the breastbone with that bypass. So this is where it usually works. Here is the lima, which is the left internal mammary artery, and it's actually an artery. And it comes down and then runs down the back of the breastbone. This is the one that is the best bypass you can possibly have. And they take it and they go from here and then they plug it in below the blockage in the heart. This is the right side, or the REMA, just trade name, as far as abbreviations. Now, these bypasses are the ones that are the veins that come out of your legs. Now, veins, when they normally are in your body, they have valves that push the blood back up to your heart so that it doesn't always pool into your legs. Well, when they do the vein, they have to turn it around so that those valves stay open. Because if the valves would shut, then it would cause the blood to clot and then your bypass would go off. In other words, it would stop. So, left internal mammary artery is the one that is used probably 95% of the time if they're going to use a internal mammary artery. And then here are the bypasses. The most bypasses I have ever seen, and again, this is just my being as far as in my career, is around 7. Usually, though, they use 3 or 4 different grafts, and then they'll do something called a jump graft, where you will do 2 vessels at once. But that's a rarity. 4, 5, but usually 3 and 4 is probably the norm. So I'm just going to pass this around.
Heart this size?
Usually. Men, it's usually the size of your fist, maybe a little bit bigger. And then with women, it's a little bit smaller. Now I want to show you some of the hardware that we use. And some of these are pacemakers and some of these are defibrillators. The defibrillators are the ones that will shock you if your heart stops beating, or if it's sitting there and just kind of, quivering. And just to make a point, there is atrial fib and there is ventricular fibrillation. As you can see, the top part of the heart is smaller. It's about the size of a walnut. That is where the atrial fib comes in. That is kind of like your timing belt is off. And you won't die if you have atrial fib. Your heart will beat out of sync, and it definitely has some issues as far as stroke is concerned. but you will not die if you go into atrial fib. The bottom part of your heart, which is the main pumping chamber of your heart, if you go into ventricular fibrillation and you don't get out of it by somebody doing CPR or shocking you, then yes, that can cause you to die. So just, you hear atrial fib and ventricular fib, VFib, that's the difference. The top part is because you can live with that because the chambers are not life-threatening. They don't pump that much blood that would keep you from living. So these two are defibrillators. This one is a pacemaker. And this one I call the born supremacy. This is like a microchip that we put in patients when they say that they're having these irregular heartbeats, but we have them wear a monitor and we never can, we're having trouble catching it, or they only have it once a month or once, every 2 months. Well, we put in a monitor in them. And this is the monitor that was the first. This came out 2 years ago. We thought this was, this was like butter. This was wonderful. Make a small incision, put it in, and the patient wore it, and then it would tell us what was going on. Well, just in the last year, same company has come out with a new device. And again, it is, you deliver it with this apparatus here. And, it's kind of like, do you people even do implants in cows anymore? I don't, I used to do that. I didn't know if it was against the law or anything. But we used to put implants in our steers, so they would gain weight and stuff. And this is kind of what this reminds me of. And I'm actually really good at this because I'm so used to putting it in a cow, with that real tough skin, that I'm actually having to show some of my male colleagues. They say, "Kris, how can you do that so easy?" And I said, "It's like putting an implant in a cow." And they went, "We don't know what you're talking about." I said, "Okay." But this is what it looks like now. This is the same thing as this in just a year and a half. So I'm going to pass this around so you can see these.
Dr. Mullins, where do you place that?
In under the chest. It's just like... not behind you. We make a... I use this little thing right here, but I'm not going to pass that around. This is my tool that I use, and it's actually just got a little tiny blade on it. And so I just puncture the skin, and I use the heart lays kind of like this. So I just kind of pinch the skin. I make a small little puncture mark, and then I put this in, and then turn it over, and then push the plunger in, and then as I pull out, this goes underneath the skin. So that's what this looks like now. So that's why I call it the born supremacy, because it looks kind of like what was in that Bourne movie.
How much does that little rascal cost?
Well, it depends on your insurance. As far as to the patient, again, it depends on the insurance. But this is what's so crazy about medicine. Like right now, for me to do a heart catheterization on a patient, and that is where I either go through your wrist or go through your groin, and I take a tube and I go up and I put dye into your heart arteries. It ranges between $125 to $250 what I get in reimbursement. And that's with a lot of radiation, possibly, and just everything that could go wrong. That's my reimbursement. I also do veins where I go up and I cauterize veins, especially people that have like varicose veins or if they have swelling. I can go and just take a little cautery tube up the vein of the leg and cauterize that vein. And the reimbursement on, again, some patients, I don't get this much because I don't do it in my office. It was just going to be too much of an issue. But people like Dr. Dr. Padula, that you might see advertised on TV, he can get up to $5,000 doing a vein on a patient. that's just a vein, you know, it's not like it's life-threatening or anything, but that is why health insurance, it's just like there's no rhyme or reason to it. You know, things that would be very risky or that have a little bit higher risk, I think it's just because that it's done more routinely versus the vein cauterization is kind of new, but it just seems like there's just a disparity between, you know, one or the other. Okay, my next prop. These are, and again, these are clean. Haven't used them on anybody. These are the tubes that I use to go up either the vessel, either in your leg or your arm, to do an angiogram. One of them is, it's called a Judkins. That's the company's name. That's the guy that developed it. So this one is called a pigtail catheter, and it goes into the ventricle. We actually will go in through the aorta and actually go into the main pumping chamber of the heart and measure the pressure here. Then we will pull out the catheter back into the aorta, and we will measure the pressure. First, we will measure the pressure in here, and then we will pull it out and measure the pressure here, and that will give us the gradient across the aortic valve. And we will be able to tell if you've got aortic stenosis. I'm sure you've all heard of that, if you need to have a valve job. So that is, but this is the catheter that we use for that. And this is called a pigtail catheter.
Dr. Mullins, how do you steer that thing?
I have a wire. I have a wire that I use that has, it's called a J-tip, but it's a kind of a little stiff wire, and the wire goes up, and then when I get to the valve, sometimes, of course, if the valve is very tight, I can't go across with that catheter, so then I have to use a different catheter and a different wire that's almost kind of like you have to sit there and it's like jump rope. And you sit there and you watch the valve and you watch the heart rate, and it's kind of like you're waiting for it to open, and then, you know, you try to get in. Sometimes it takes a while. You have to be patient. But, you know, that's the way that we can measure the gradient between the two.
Are you watching this
On a screen under fluoroscopy. This catheter is designed to go against the aorta, this area right here. It has a bend, and it actually will bend into the left main artery. So this is the left side.
Does that have a camera on it or something, or you put a camera in there too? Or?
I'm looking at it under X-ray, under fluoroscopy. Okay. Now we do have where we have a camera that has ultrasound to it.
Which end do you stick in there?
The end that's bent?
The end that's bent.
Yes, I have a wire that's inside that.
Oh, okay.
And I take that wire up in front of it because it's got a little, almost like a little, you know, it's called a J-tip, but it's a very soft bendable, so that if I get in something I'm not supposed to, I can feel the resistance. Also, being a cardiologist, I hate it when I burn my fingertips when I'm cooking, which is not that much, but as far as cooking goes, because I'm so tactile with my fingers. This is how I move my wire when I'm putting a wire down your artery to put a stent in. You know, it's all feel. And, you know, looking is great, but I can also, you know, I know when something's going like it should by the way it feels. So.
Is a stent, how big is a stent? I mean, this is a pretty small wire.
Mm-hmm.
Is the stent that small?
The stent is that small. But then, you know, again, it's on a balloon that looks kind of like a circus balloon. And when you blow up the stent, then it expands like, you know, then it's like rebarb in the vessel, the wall of the vessel. Now, stents in the heart, you know, they come in different sizes, different shapes. Some patients that are not bypass candidates, I will put stents from you start at the bottom and work your way up. We call it a full metal jacket. So sometimes they'll get a full metal jacket. And then I, you know, do stents. We can do stents in the distal aorta, where if there's an aneurysm. I also do stents down the leg for people that don't have, that have, we call it peripheral vascular disease, where their leg has a wound, either from poor circulation from smoking or diabetes. But we have learned our lesson that below the knee is not a good place to put a stent, because the flow is slower and gravity makes things sort of more stagnant, that the stents have now become more of an issue, and we don't do stents below the knee. We go out and we clean them. We actually have an apparatus that's almost like a plane, like you would plane a door. Well, I actually have a piece of equipment that I can go in and cut out the blockage out of the leg and clean it out, and it actually will get stuffed into the bottom part of my apparatus when I'm planing it. I'll cut it and then I'll pack it, and then I can pull that stuff out. But
you've learned to not put them below the
yes,
knee.
and again, this is all from cardiologists. We thought, okay, we can stent everything. We'll put stents down the knee, behind the knee. Well, if you put it behind the knee and people bend their knees, those stents, I don't care how strong they are, they're eventually going to kink. So we quit doing that. And then we realized that the people that just had the balloon procedures, as opposed to people that had the stents, did better. So then we quit putting stents in, and we try to figure out other things that we can do to open up their legs. And now the next course that I'm going to be going to, I just got back from Mayo, the next course I'm going to be going to is actually going to a cadaver course, to where I'm going to start going from the feet up to see if we can do a better job as far as working on the feet and the legs of patients. I can tell you that I have patients that they are grateful and they are happy after they have had a heart attack and you put a stent in their heart. But I can tell you, the people that you save their legs, they are beyond grateful. I mean, if someone loses their leg, especially if it's above the knee amputation, their risk of being dead in 4 years is at least 25 to 30%. And the cost to the medical, to society goes up dramatically, because they're going to need special equipment. They're going to need to have more nursing care. They're going to have more problems with bed sores, and they're going to have more hospital admissions. So save a leg, save a life is what we're...
Are most of those feet and leg issues diabetes related?
That and smoking. So, yes, sir.
How do you maintain the integrity of the valves and those things when you're running wires and stuff up through it?
From the if we're talking about the veins, that as far as
I'm talking about the valves that actually keep the blood from going back down.
that's, a lot of times that's when we go in and have to cauterize them, because they become where the valves don't work anymore, and the patients have what we call venous stasis ulcers, because the blood is just sitting there pooling, especially on the outside of next to the skin. And that's why we go and cauterize those peripheral veins to make the blood get diverted into the deeper tissue, and then they don't have issues with those sores.
Do they need to wear support hose or something like
Support
that?
hose, diuretics, propping your feet up and everything. Yes, sir.
Borderline diabetic. You was talking about a little bit ago the blood vessels, I guess, in the legs.
And in the
strained
heart.
to almost nothing. What is? I assume there's some type of test to know if you're normal or shrinking. Or
Well, they can do it with an ultrasound a lot of times, but of course in the heart, it's we have to do an angiogram. And again, it happens over a period of time with diabetics because of the high sugars and also the stress hormones. There's a lot of what we call remodeling of the vessel, and it just keeps getting smaller and smaller. And if they smoke on top of that, it's even worse. So.
Well, I'm a borderline diabetic, and I do not smoke. But in the last year, I'm not saying it goes to sleep. It just seems like my legs kind of swell up a little bit.
Mm-hmm.
And I don't know if it seems like every time I go to the doctor, my blood pressure and stuff's fine, but I just wondered, is there a test they can do to?
Probably an ultrasound.
Ultrasound?
That would be the least invasive test and the easiest test to do. Either an ultrasound, or they sometimes can do what's called an ankle brachial index. ABIs is short. But what they do is they put a blood pressure cuff on your arm and a blood pressure cuff on your legs, and they measure the different blood pressures to see what the flow is like. Is the flow in my legs the same as what they are in my arms? So, yes, sir.
Boy, I tell you, you're kind of scaring me to death. My dad died of defibrillarization. He was 44 years old. This was back in 1968. They did not have defibrillation machines in the hospital emergency room. I was 6, as I said. I know sometimes early in the morning, I'll be out at Walmart, and I may be kind of stressed to get the shopping list done. My heart will go, I can feel it. It'll go a little wild. What I do is I start coughing. I take deep coughs, and I cough, and I cough, and then I take my hand and whack.
Maybe you ought to go have a check.
I was gonna say, you're scared nerdy now.
I used to take 81 milligrams of aspirin every day, but I found out that makes me anemic. So I'm not on aspirin anymore.
Probably what I would suggest and again, start with the least invasive test. Does it do it every day?
No,
Okay.
It's just mainly happens in the mornings.
Okay.
And
If you're kind of stressed out or
out, I've got to run like hell through Walmart.
Okay.
And because I've got a tractor waiting for me.
Okay. Okay.
But yeah, my heart history ain't very good.
What I would probably suggest, the least invasive thing, would be to maybe have you do a stress test, put you on a treadmill, and then have you wear a monitor if you don't have any problems on the stress test. You know, and a stress test, as far as I was telling the gentleman here, I went to Mayo Clinic for a review course, and they were talking about doing a treadmill test, and the guys in New York City that I was sitting with kind of made fun. They said, I haven't done a regular treadmill in years. And I looked at them and I said, I do them every day. And they kind of looked at me like, oh, you hillbilly hick. And I said, look, I said, things are not, I said, you live in New York City where I said, there's things readily available. And I said, I drive 3 hours, once a month to go to, the rural outreach in Oklahoma. And I said, and there are people that are hardworking people. And I said, I'm not going to make them turn around and drive 3 hours to Oklahoma City. I said, sometimes they can't. And I said, but if I can do a treadmill where I put them on a treadmill and see what's going on, and that answers the question, I said, that answers, I can do a lot with that information. And a treadmill test in Oklahoma is the same in New York City as it is in California. It is a standard. You get on the treadmill, it has a certain, as far as rise, and it goes a certain amount of speed every 3 minutes. Every 3 minutes it gets a little higher and a little faster. If you can go 9 minutes on my treadmill without having any issues, you have a risk of less than 1% chance of something bad happening to you in the next year from cardiac disease. And again, that has to do with blood flow and stress. We look at workload. It's just like if you're kind of really, revving up your tractor engine, and that oil light comes on. It's like you need to pay attention. Same thing when I have you on the treadmill and I start seeing changes in your EKG. I'm putting stress on your heart and it's telling me that it's not getting enough juice. So it's kind of the same thing. So again, I would recommend stress test possibly and a monitor.
I took a stress test once. I think I was in my late 30s, and I passed it with flying colors.
How old are you
But
now, sir?
I'm 53. And, well, see, a number of years ago when we had that record hot summer where it was we were over 100 degrees every day for, 70 days or more.
Mm-hmm.
I could barely go. And I went over to Enid to Integris, the Heart Institute thing they got in one hospital.
Yes.
And I was so tired. I told them, no, I don't want to run the treadmill. I'll take
The chemical stress
the
test.
chemical injection. I was so tired. I said, no, I don't think I'd flunk the treadmill. I told them that.
Mm-hmm.
And so I paid the extra money out of my back pocket for the injection. Yeah, they injected me. More than they put me downstairs and they took pictures. I knew that thing goes around and around.
Right.
Well, I all came, now this was like maybe 4 years ago. And I come out once again in flying colors. The doctor, I can't think of his name, but he and they gelled me all up. They gelled everything. And I don't know, I came out in flying colors, but
Well, let's
It's
see what
just-
happens. It would be great if you could have a monitor on when you're having those symptoms. That would tell us a lot.
yeah.
Well, guys, thank you for letting me come and talk to you.
Thank you.